Hello everyone. Now we are in the diagnostic procedures. What we are going to do to reach a diagnosis. So the first step of any diagnosis, it always starts by medical history. The medical history is a mandatory step for every case treated in our dental clinic. So this procedure starts even by the front office where the patient is going to apply. This should be like a questionnaire, and this questionnaire, it should include any systemic diseases the patient is suffering from, any drugs taken by the patient, any allergies by the patient, okay? And this medical history, it should be updated every visit. Then we are going to follow a special format called SOAP format. So the S, it will be a subjective. I'm going to interview my patient or ask patient some question, or the patient is going to tell me some of the symptoms he has. Then the objective, I'm going to do some clinical test or radiographic test, and then the assessment or appraisal where I'm going to formulate a diagnosis, and then finally a treatment plan for this patient. This should be the systemic procedures I'm going to follow. So our diagnosis, of course, it starts by the chief complaint. So the chief complaint is what the patient, what are you seeking advice from the dentist? Why are you here for the dental clinic? So this should be expressed by the patient and in his own word. Then the history of the chief complaint. I'm going to ask about the chief complaint. If there's pain, is this pain localized or not, or it is diffuse? When does this symptom start, okay? Is it a few days ago, a few hours ago, or a few months ago? The intensity of the pain from 0 up to 10, okay? How it looks like. Is it a 1 to 3, or it's a moderate 6 to 7, or it's a severe pain from 8, for example, up to 10. The duration of the pain, is it a sharp momentary pain? It's just subside after removal of the stimulus, okay, like drinking or mastication, or it will linger or last for a long time, okay? Any provocation factors or attenuation factors, anything that can increase the pain or anything that can decrease the pain, like for example, drinking hot or cold or taking sweet, okay? So this could be increasing the pain or decreasing the pain, okay? By the end of this interview, I should make like a tentative diagnosis, a primary diagnosis from this interview with the patient. Then I'm going to proceed to the dental history, okay? It is the dental history, it's about the events that have led up to the chief complaint. Maybe it could be related to a recent filling, okay? Maybe it is related to a trauma or any dental procedures that have started before the chief complaint occurs. So it's also important to be documented every step I'm doing or during my treatment, the progress note, it should be properly documented in my dental history. Then I will start my objective tests. And the objective tests, it will start extra-orally. I'm going to examine the skin, the color of the skin, any facial asymmetry or any swelling or any deviation from the normal anatomy, any presence of a sinus tract extra-orally, examination also of the lymph nodes, examination of the TMJ while opening and closing. I'm going to see if there's any deviation during opening and closing. Then we will start the intraoral examination. I'm going to examine the soft tissue and I'm going to examine the hard tissue. I will start by the soft tissue. I'm going to examine the buccal mucosa, the labial mucosa, the alveolar mucosa, the hard palate, the soft palate, the floor of the tongue, the lateral borders of the tongue, the retromolar regions, even the pharyngeal wall, they should be examined. So I'm going to start with the soft tissue. Then I'm going also to examine intraorally to see if there's any swelling. If I see any swelling, I should mention or I should know this swelling is a diffuse swelling or it's a localized swelling. Is it a hard swelling or it's a fluctuant swelling? The treatment will be sometimes different if it's a fluctuant or it's a hard swelling, okay? The location of the swelling, is it location at the mucobuccal fold or it is located at the attached gingiva? This is again can differ in the diagnosis. Then I'm going to examine the teeth. I'm going to examine if there's any discoloration, any kind of fracture due to a trauma, for example. Any caries, of course, should be mentioned or it should be written, okay? Any failing restoration, any fractured restoration, any non-carious lesions like, for example, the abrasion, the attrusion, the attrition, for example, the effraction, all of this it should be examined during the intraoral examination. So I started by the soft tissue examination, then I moved to the examination of the teeth themselves. Then I'm going to examine the periodontal ligaments. Okay, this is through the percussion. Percussion is like gentle tapping on the occlusal or the incisal surface. This can be done digitally by my finger, or it can be just gentle tapping by the end of the mirror. So what I'm going to get from the percussion, it will give me an idea about the periodontal ligament, the status of the periodontal ligament. Are they inflamed or not? Okay, so it has no relation to the vitality. Okay, the vital tooth, it could be sensitive to percussion, and the non-vital tooth, it could be sensitive to percussion. Another method of detection, the status of the periodontal ligament, is the palpation. Palpation by rolling of the index finger and just trying to make some pressure at the apical region and see if there's tenderness on palpation. If there's an inflammation in the mucoperiosteum, there will be like tenderness on the palpation. Also, palpation is useful in detection if I have a swelling, if this swelling, it's a fluctuant swelling or it's a hard swelling. Then I'm going to examine the periodontal ligaments by detecting the mobility, okay, by putting two mirrors against each other and see the degree of mobility in a buccolingual direction. Also, one of the examination or one of the objective examination is the bite test, where I'm going to let the patient bite on some object like the tooth loose or a tongue depressor, for example, or a wooden stick, or a rubber cup, or a cotton roll, all of this to detect if there's any cracks in this tooth. One of the characteristic features of a cracked tooth is the sudden pain on opening after biting on a hard object. Okay, so biting test also, it could be a valuable tool or a valuable test in detection of the cracks. Then I'm going to examine the periodontal ligaments. This is through the periodontal probing to detect the health of the attachment apparatus, if there's any deep pockets or not. Or there's a wide pocket or a deep narrow pocket. Deep narrow pocket, it could indicate presence of an endoperio lesions, like the primary endodontic lesions. Okay? Or it can even indicate presence of a vertical root fracture. So, periodontal probing is one of the mandatory tests during the clinical examination. Then we come to the pulp vitality test, or I can say to the pulp sensitivity test or sensibility test. This is through activation or excitation of the neural nerve endings present still in the pulp. So if there's a response, okay, this means that the pulp is still vital. And if there's no response, mostly there will be loss of vitality of this tooth. Okay? This pulp sensibility or sensitivity test, it can be done either by thermal or electrical. Thermal, it includes both the cold test, and the most common way of detecting vitality using cold test is by the refrigerant sprays. Okay? So I'm going to dry the tooth and apply a cotton pellet, and this cotton pellet, it will be applied on the midfacial buccal surface and see the response of the patient. Also other ways, by spray with cold water or carbon dioxide ice, which gives like a very low temperature. It can be used in the cold tests. Other kind of test is the heat test. Okay, other kind of thermal test is the heat test, where I'm going to apply heat, okay, on the labial surface of the tooth, either by agateperca stopping, either by a hot compound, either by rotating a rubber cup and waiting from the patient to see the effect of this application of heat. If there's any still response from the nerve ending, the patient, he will respond by pain. Remember that the pulp, it will not respond to cold or hot, it just responds by pain, okay? So what about the result of the thermal test? Thermal test, it can give a normal response, which is just a momentary, sharp momentary pain, which will subside after the removal of the stimulus. What about the abnormal responses? Abnormal responses, it could be loss of pain, there's no pain at all, and this could indicate a presence of pulp necrosis, okay? Or lingering pain or prolonged pain after removal of the stimulus. So lack of response or lingering pain, both are abnormal response of the pulp. Another way of detecting sensibility of the pulp is the electric pulp testing, where I'm going to apply electrical current to the tooth and waiting to see if there's any response. Of course, it's a mild electrical current. I'm going to dry the tooth, apply a toothpaste at the midfacial surface, and then applying the electrode on the midfacial surface, and then increasing gradually the electrical current from the EPT and waiting for the response from the patient, okay? Another valuable test is the caries removal, to see the extension of caries. When I cannot determine the extension of the caries, I need to remove the caries, which will add to my objective test and add to my diagnosis if I can see if there's an extension of caries to the pulp chamber. Anesthesia testing is very important test to differentiate between the pain if it is coming from upper or lower teeth. This is a very valuable test if there's referred pain and the patient cannot determine whether the pain is from the upper or the lower. So it will start by giving intraligamental anesthesia from the posterior maxilla, giving like 0.3 millimeter of anesthesia and waiting to see if the pain will subside or not. Other kind of objective test is the staining and transillumination. Staining, if there's any fracture line, okay, transillumination is providing like a fiber optic light on this tooth. If there's any line of crack, this crack, it will absorb the light and it will appear like a dark line in the tooth, okay? Staining, like adding methylene blue, for example, okay, adding a dye or methylene blue to the tooth, it will help in appearing, or the crack line, it will appear very clear during the transillumination process. So staining and transillumination both are valuable tests in detection of cracks. Test cavity, it could be mentioned as the last resort when all the tests are non-conclusive. I didn't get a clear idea about the state of the bulb. Is it vital or non-vital? Then I'm going to start doing a cavity in the dentin without anesthesia and waiting from the patient response. If there's any sensitivity, this means that this tooth is still vital, and I'm going to put like a restoration to fill this cavity that have been done. If during the test cavity no response, so I'm going to continue to open access cavity. The last resort and the last test I'm going to do to complete my picture is the radiographic examination. And this is very important test. And this is, as you can see, it is the last test. I cannot build my diagnosis until I do a radiograph. But again, radiograph, I cannot determine a diagnosis only from the radiograph. Okay? So radiograph, it will complete my puzzle. Okay? So during the radiograph, I'm going to see if there's any caries and the approximation to the pulp chamber, if there's any deep restoration, if there's any previous pulp capping, if any pulpotomy have been done, if there's any calcification in the pulp chamber or root canal, any resorption. It will give me an idea about the bone, if there's any bone rarefaction or radiolucency. If there's any sinus tract, I can place agataperca and see where it is going to or where it is heading to, or determining the tooth that is causing this problem. It will give me an idea about the periodontal ligaments and if there's any widening in the periodontal membrane space or not. It will give me an idea about the root presence of curvature, or it can give me an idea about the length of the root. The last thing I'm going to talk today, it's about cone beam computed tomography. Cone beam computed, or the CBCT, it have became now a very important tool in endodontics. Okay, cone beam computed tomography, it's like an X-ray source and the sensor rotating around the patient, and while it is rotating, it is taking many shots or many captures for this tooth or for this region, and by the software in the CBCT, it is going to reconstruct a three-dimensional image, so to see the third dimension that I cannot see by the periapical radiograph. Cone beam CT, it is now used in the diagnosis of many cases. So I can clearly see the presence of radiographic or periapical lesion. Also, it's very important in treatment planning for a complex root anatomy. If there's any resorption, if there's any, I need to determine vertical root fracture. Also for assessing the diagnosis or treatment outcome for follow-up after treatment. So cone beam computed tomography for nowadays, it is a very important tool in endodontic diagnosis. After this all test, I can clearly determine, or I can complete my picture to finally get a definitive or a final diagnosis. And thank you, and see you in another topic next time. Thank you.